Hello students, welcome to this class. Let us see what we have in this class today. Now when patients suffering from chronic illnesses try to get back to normal, when they try to get back to the road to recovery, there are a number of problems that they need to face. There may be personal problems, there may be social problems, there may be physical problems that they have to overcome. And the successful dealing with these obstacles determines whether they come back to normal and how normally they can live their lives. And this is where rehabilitation comes into play. And yes, in today's class, we are going to deal with rehabilitation and its necessity for chronic illnesses. Now, rehabilitation in simple terms refers to restoration or bringing the person back to normal, restoring him, reinvigorating him. And rehabilitation programs may either be long-term or short-term, in the sense that certain patients may need to be institutionalized. For instance, if a person has suffered a stroke, it may not be possible to deal with such a person in a short-term format. We may have to hospitalize the patient, or he may need long-term care even at home, and the rehabilitation program becomes more of an institutionalized based program. On the other hand, most of other rehabilitation programs are quite short-term. They are outpatient ones, where for 2 or 3 months the patient undergoes intensive therapy that prepares him for life outside the hospital. Now, a lot of rehabilitation professionals are involved in this job of rehabilitating patients and bringing them back to normal. A team can consist of a physical therapist or a physiotherapist who deals with all the physical aspects of the illness, such as bringing more activity, power, and more movement capacity into the person. There may be occupational therapists who deal with a whole lot of things, such as teaching the person daily living skills to rehabilitating him in the vocational realm. Then there may be dietitians who deal with the dietary aspects of the person's life so as to bring him back to normal. There may be social workers and psychologists who deal with a host of emotional and psychosocial factors and make sure that the person gets a very good support system around him so that he feels protected and reassured when he steps back into active life. In addition to all these many professionals, perhaps the most important pegs in this wheel of rehabilitation are two. One is the patient himself, because the patient knows best about his illness. He knows best about what he is feeling, what his symptoms are, and what little recovery or improvements that he is having. In fact, even the doctor may not know as well as the patient about the patient's illness. And secondly, the patient is also very important in the rehabilitation process, because his co-management of the rehabilitation process in addition to these professionals is what matters. Because even though we looked at institutionalization and short-term rehabilitation as two types of rehabilitation, in fact, no kind of rehabilitation is short-term. You may teach the person skills for 2 to 3 months, or you may teach the person skills for 6 to 8 months. But the person will have to continue with the adherence to these kind of skills and techniques probably for years together. So rehabilitation is always long-term. And unless the patient is motivated to do it, rehabilitation cannot succeed. Another important peg in this rehabilitation process is, of course, the family, because the family is that unit which can help the patient adhere to the treatment, give a lot of support, both emotional and material, and ensure that the rehabilitation process is a success. Physical rehabilitation. Now, in this class, when we deal with the importance of rehabilitation for chronic illness, we will be dealing with certain areas in particular. We will be dealing with physical rehabilitation, social rehabilitation, of course, vocational rehabilitation, because these three areas, in fact, encompass almost all the aspects of a person's life. And finally, we will be also looking at adherence, because how much ever rehabilitation efforts we put in as professionals or the family puts in, finally it comes to adherence, or whether the patient follows the rehabilitation regimen to see whether rehabilitation really becomes effective or not. So firstly, we come to physical rehabilitation. Now, any kind of chronic illness, of course, has as its side effect or as its subsequent effects a lot of anxiety, depression, frustration, irritation, and hopelessness, and a lot more of emotional feelings. And any kind of rehabilitation that promotes physical activity in the person, which improves his scope of movement, which improves his scope of action, can be very useful, because it helps the person come back to a more normal life. It helps him to manage his own daily living tasks and gives him a sense of self-control and self-confidence. And ultimately, it can do a lot in improving his psychosocial adjustment. Now, depending upon what kind of illness is involved, the physical rehabilitation goals and the physical rehabilitation techniques may differ. Now, there may be certain diseases, for instance, a lot of cardiovascular diseases, other diseases such as, say, asthma or pulmonary disorders, in which exercise, apart from improving activity levels, acts as a measure to reduce the symptoms in themselves. Because exercise here is one factor which can reduce a number of symptoms associated with cardiovascular, pulmonary and other asthma related problems. And when these symptoms reduce, automatically the patient's level of well-being increases. And this improvement in activity is again a subsidiary benefit. Now, there may be certain other kinds of illnesses and injury. For instance, a patient has a fracture, or he has had an accident and there is a surgery involved. Or there may have been certain injuries which are not of the present moment. They may have been, incurred in childhood. Say there is a knee injury or a shoulder injury, there was a surgery or some kind of treatment and the patient recovered. But now when the patient has a weak bodily state, or say for instance that he is aging now, he is becoming more elderly, these problems may again crop up. So here physical rehabilitation will have another direction to give. What it can do is firstly reduce pain, reduce all the symptoms that are involved in these kinds of illnesses, reduce the discomfort that is involved in movement, improve the scope of movement, probably train the person to use a number of assistive technologies such as crutches or wheelchairs, or say if the patient has a leg which has been amputated, the rehabilitation therapist can help the patient use a prosthetic limb and other such devices. Similarly, physical therapy may also look, in rehabilitating the patient in such a way that he knows what are the limits of his activities. And he also knows that when am I going to face a crisis in my activity, when I have to be careful, and how can I manage my physical energies in such a way that the expenditure of energy is less and I can attain more movement. So these are the kind of plans that a rehabilitation therapist will do in the physical realm when a patient has certain injuries, surgeries and such kind of issues. Now, a very interesting factor that has been seen, particularly in case of this kind of physical rehabilitation that we have talked about, is that group therapy seems to be more effective than individual therapy. Now, what can be the reason for this, greater effectiveness of group therapy? Because this can have important implications, and, patients can be more encouraged to go in for group situations of therapy. One reason is that when you are in a group therapeutic situation, you meet a lot of patients who are experiencing similar pain and discomfort. So you always feel that you are not alone, you are not isolated, you actually have company. There are other people also suffering in the same way. And secondly, when you see such a lot of people trying to recover, trying to improve, their skills, it gives you a lot of encouragement and motivation that yes, I too have to do something. There are people, others who are suffering like me, who are trying to get better. So I also have to do my share of effort. And thirdly, one basic advantage in group therapy is that, as you know, rehabilitation really involves a lot of pain and discomfort. The exercises which are meant to reduce discomfort actually also cause discomfort and pain in the process. Now, when you are a participant in a group exercise, many a time the focus shifts from the pain and discomfort because you have company, you are more focused on other people, there is a diversion of attention. So physical therapy in fact becomes easier. Now, a third kind of physical rehabilitation may be necessary for certain patients who are in fact having symptoms or having side effects of the treatment in itself. Say hypertensive patients, their medications may lead to a lot of problems such as breathlessness, it may lead to problems such as obesity and weight gain. Say for instance cancer patients, the treatment involves chemotherapy, and many of us know that chemotherapy in fact has a series of side effects, from nausea, vomiting, diarrhea to a lot of bodily pain and discomfort. So physical therapy in these cases will look not just to reduce the symptoms of the illness, but in fact to reduce the side effects of the treatment in themselves. So the physical therapist may have to deal with programs that involve, dealing with taste aversions, looking at, maybe speech therapists who will help the patient speak better if there is any kind of slurring caused by the medication, or physical therapy that may seek to increase activity and reduce obesity or improve cognitive functioning, because many of these medications also involve decline in cognitive functioning. And one basic factor that we do not know is exercise not only improves bodily activity and bodily functioning, but in turn it also has effects on the mind. It makes your brain work faster, it activates your mind as well. So for those patients also who are having side effects such as memory problems or cognitive problems, exercise can be very useful. It reactivates them cognitively. Physical rehabilitation, a comprehensive approach. So since we have narrated the different kinds of physical rehabilitation that may be required for patients having different kinds of illnesses and different kinds of treatments, what we should keep in mind as patients or as caregivers of patients or as people who are closely involved with physical therapy is that any kind of physical rehabilitation ought to be comprehensive. You have to take into account everything, both the illness factors plus the treatment factors, as also those key areas where a patient wants urgent improvement, because when a patient gets those kind of results, he becomes more motivated to continue with the therapy. For instance, certain patients may need a lot of pain management. The first task for them would be to reduce pain and discomfort. Or for certain others, they may need a lot of skills to use assistive technologies. As we mentioned, there may be prosthetic limbs, there may be crutches, wheelchairs or calipers, and a lot of such instruments that they need a lot of training to use, because these are going to form a part of their daily lives now. And there may be some others who may need a little more complex physical rehabilitation, such as reconstructive surgeries. This is often seen in cancer patients. For instance, those patients having breast cancer who have gone in for a mastectomy may opt for cosmetic surgery such as breast reconstruction. Those who have undergone surgeries for cancer in the jaws, they may go in for jaw reconstruction. So these kind of cosmetic surgeries, advice on how to go about them, whether the patients are suitable or not, also becomes a goal of the physical therapist. In addition, there may be patients who have Parkinson's. For them, cognitive, behavioral and physical therapies need to be put in together so that their motor skills improve, their cognitive skills improve, and they have less of tremors and shaking. Similarly, patients who are suffering from stroke, diabetes and similar such disorders may have a lot of cognitive problems. So physical therapy should be modulated in such a way, as we said, also to improve cognitive functioning. A fact to be noted here also is that stress is one major factor which can create a lot of problems in the chronic patient coming back to normal. It can actually increase the kind of symptoms and discomfort that is involved. So when you are framing a physical therapy program, or when your physiotherapist or the physiotherapist of your family member is framing such a physical therapy program, it is also important to see the stress factor, what kind of stresses are involved for the patient, and incorporate these factors also into the treatment. For instance, you understand that the patient experiences a lot of stress towards the evenings. Most people have this kind of anxiety, or when they are lonely, maybe the physical therapy can incorporate something such as a short walk or a visit to the park. So two goals are met. Firstly, the patient gets a change of mind. Secondly, his activity levels also improve. So dealing with stress also should become a component of comprehensive physical therapy programs. And something which also needs attention, sadly, is that many patients who are chronically ill need a lot of assistive technology to help them. But unfortunately, the access to this assistive technology is not equal for everyone. Patients who are in the upper socioeconomic strata or who live in cities have a better access to these kind of technologies as compared to patients who are more vulnerable, in the sense they are from the lower socioeconomic strata or are from rural areas. So again, bringing these technologies to the patient for a better recovery also becomes a role that a physical therapist has to play. Occupational rehabilitation. Now, apart from physical rehabilitation, one very key area where a chronically ill patient needs to be rehabilitated is the vocational sector, or he needs to be rehabilitated back to his occupation. Now, as we know, occupation is a very important thing for a person. A person's vocation or career is not only a source of bread and butter, but it is also something that maintains the person's contact with an active life. It maintains a person's contact with the society. It determines his social identity and social status. And one major problem that chronically ill patients face is that when they come back from their illness, they face a totally different world in which their basic source of sustenance, that is their vocation, is also lost. Now, people who are chronically ill may have to face a lot of changes when they come back to work. For instance, a person was involved, say, in an occupation which involved a lot of running about and supervising, and now he has something of a spinal cord injury. So he can no longer do a job that involves a lot of movement. He would need a job that requires sitting in one place and doing all the necessary tasks. So there is a job readjustment that is necessary. And many jobs do not offer this, either because there is no option for the same, or because many employers don't feel it necessary to do a lot of accommodations for a chronically ill patient when they can easily get someone else to work from the ever-waiting job force. A second factor is that many patients who have certain illnesses which have a stigma attached to them, say AIDS, cancer, leprosy and the like, are often laid off from their jobs because it is clearly told to them that their medical condition is a reason, even if they have recovered, even if they are on the road to recovery, because many of these diseases can be actually completely cured. But even then, they are stigmatized and told that with their medical condition, they cannot continue with the work or with the current profession. So there will be a lot of reasons that will be told to them. They will be informed that if they continue with the jobs, their colleagues are not comfortable, they may probably leave their jobs, or the company would get a bad name, and so on. So job layoffs due to chronic illness is one factor. Secondly, if the illness is not such a stigma factor also, many workers are laid off because the company feels that they may not be able to perform as well, because the company is after all paying them and they need a lot of on-time work. And even if they are not laid off, they may be denied opportunities for promotion or advancement, because the company feels that training such people, spending such a lot of money on such people who have a medical tag attached to them and who may fall sick is really an investment which may not be really worthwhile. So there are a lot of issues that are involved as far as chronic illness and vocational rehabilitation goes. Now, one major thing that needs to be done is that there should be an early identification of these problems. Most often patients, their caregivers and also the rehabilitation functionaries become so involved with physical rehabilitation that they forget this aspect, and by the time they come to this aspect, a lot of damage has been done. So both patients, caregivers as well as the rehabilitation therapists should focus on occupational or vocational rehabilitation right from the beginning. All the possible job difficulties that may arise should be identified, and then the rehabilitation therapist can work on it one by one. Sometimes it may also involve a lot of advocacy. For instance, the therapist may have to speak with the employer and make him understand the reality of the patient's condition, that he or she is still capable of continuing in a job, or convince him probably to give him a position that is much more suitable for him, much more convenient to him if it is possible. If such a thing doesn't happen, of course, the rehabilitation therapist may have to teach the patient new job skills and assist him in finding a new job and new opportunities. And in some cases, job training, job counseling would also be required. And one important factor that the rehabilitation therapist will have to train the patient to do also is to face discrimination and to fight against discrimination. Because in the initial stages, the rehabilitation therapist can himself play a role to remove all possible misunderstandings from the minds of the employer and the colleagues and so on, and he can try his best. But after some time, when the patient actually goes into the job and starts working, he may always have these stray cases of discrimination coming up at different levels. It may be overt or it may be covert. So the patient needs to be strengthened mentally and emotionally, and he needs to be sensitized as to how he can tackle discrimination on his own and maintain his sense of self-identity and self-efficacy. Social rehabilitation. Now, very large and very important area of rehabilitation for the chronically ill patient is what is called social rehabilitation, because one major deficit that chronically ill patients face is the deficit as far as social relations are concerned, because the amount of hospitalization, the amount of treatment and care that is required, and the physical limitations that follow make it difficult for the patient to maintain an active social life. And it also creates a lot of complexes within the patient. The patient, may act in extreme ways. He may try to isolate himself from the society, or he may try to, engage too much into social activities, something which his health does not permit, and in any case, it is going to be disastrous. Or there may be situations where the patient complains that others are not really, dealing with him properly. They are just pitying him or giving, sympathy, whereas he himself may behave in ways that elicit, sympathy and pity. So there may be a lot of factors that are involved, because chronic illness in fact creates a lot of feelings of inadequacy in the person. Now, the problems in social relationships may not just be on the side of the person. Friends, family, relatives and others may also be a part of the problem, especially if the person has some kind of stigmatized disorder, as we mentioned, something like AIDS or leprosy or cancer. Relatives and friends may have a lot of problem in dealing with the patient. They may have a lot of misunderstandings associated with the condition, and they may want to keep away from the patient. Or in some cases, they may come and they may give a lot of verbal warmth and affection, but in actual action it may show that they actually have a lot of problems with the patient. For instance, common examples include relatives coming over and saying a lot of nice words, but they would refrain from holding the patient's hands or touching the patient or having anything in the home, because they have a lot of stigma and misunderstanding associated, and this actually transmits to the patient, because the patient would also be noticing all these factors, and it causes a lot of hurt and a lot of disappointment also. Again, usually it happens that in the primary stages of the illness, many friends and family do come over and visit the patient, but after some time they also become busy with their own lives. And again, social relationships always involve a lot of give and take. Now the patient is in a position where he can only take and he cannot give. So after some time, others may also get tired of this process, and slowly they stop coming. There is a vacuum which is created, which again creates a lot of issues. And family is one big factor, because family, of course, in most cases does stay with the patient, but they in fact need rehabilitation on an equal level as far as the patient is concerned. Because family faces a lot of stress. Firstly, they have the very shock of the diagnosis that someone in their own family, someone very close to them, is no longer going to be healthy or is having to face a lot of problems. And they face a lot of pressures, time pressures, financial pressures, trying to deal with all these additional responsibilities, because they themselves may have other responsibilities. They have their own families or children or spouses and their own careers. So dealing with all of them and dealing with the sick family member becomes a lot of pressure in itself. And unfortunately, the situation is also that even if families give a lot of care to the patient may not always accept it with gratitude. And this is not the fault of the patient also. The fact is, the patient is himself, in a state of a lot of complexes, in a state of disturbance. He may feel that any sort of help that is given to him is sympathy or pity, and he may resent the kind of help. So even if the family gives a lot of care also, the patient may actually behave with them in a way that is not appropriate. So all this again adds to the stress experienced by the family members. So rehabilitation here has to be three-pronged in fact. Firstly, it should deal with the patient, teach him newer social skills, encourage him to take part in social activities that are appropriate for him, encourage him not to, put himself into isolation, to actually take part in small-time leisure activities, to go out, meet people, maybe join in certain kind of interest groups if he's interested in certain things, say, reading or music or exercise or anything of that sort. And one major factor that can help is support groups. Support groups usually exist for certain diseases in themselves, like cancer support groups or arthritis support groups. So when the patient goes into these support groups, the kind of social support and social interaction that he receives is very good, because all are people who are suffering in the same way. A second aim of rehabilitation would have to deal with the family and friends of the patient. The friends, relatives all need to be sensitized about the illness, about the various factors related to the illness, and any sort of misunderstanding should be removed. And they can also be educated how simple visits or phone calls or messages can in fact have a lot of effect on the patient, can bring the patient back to active life. And thirdly, the family. Family may need a lot of care and assistance, and they may need a lot of rehabilitation also. Therapist may need to help them plan out or replan out their lives and find the time, find the energy to deal with the new situation. Family therapy may be required at times to solve any kind of frictions or conflicts that have happened between the family members. And there should also be scope created for the family to take some break for themselves, to go out, to spend some time for themselves, and the therapists can arrange for certain support groups or certain auxiliary caregivers who can take care of the patient while the family also has some breathing time. Adherence. Now, one very last but very basic factor that we are going to look into is adherence, because this becomes the crux of this entire rehabilitation system. Because apart from doing all sorts of rehabilitation, the rehabilitation therapist has to ensure that the tasks and techniques that are applied on the patient, that are taught to the patient, are actually followed or are adhered to. Now, there can be a lot of problems that happen in adherence, because any kind of rehabilitation process involves a lot of changes. There are a lot of lifestyle changes involved which are quite hard. For instance, cessation of smoking, reducing alcohol intake, eating a very balanced diet, or going in for regular exercise, or going in for a lot of painful physical therapies. There may be a lot of things that are involved, and interestingly, none of these bring immediate results. So the patient gets frustrated that why have I to follow so many regimens, so many life limiting regimens, when the results are also not clearly available. So this may reduce the motivation and adherence levels fall. So the aim of the physical therapist again becomes two-pronged. One is cognitive behavioral, second is plain education, simple education we can say. In cognitive behavioral therapy, adherence can be taught. In fact, basically behaviorally, the patient can be given small goals to undertake. If you are talking about maintaining lifestyle or continuing exercise for 1 year, it may be something difficult for the patient to imagine. So what the therapist can do in collaboration with the psychologist is to create small tasks for the patient, small chunks, say 1 week of adherence at a time. And once the patient agrees to that, once the patient successfully completes 1 week, automatically he can be rewarded in some way. He can reward himself, in fact, do something that he likes, and go into the next week. So week by week, adherence is planned out such that slowly there are permanent changes in behavior, and adherence becomes a matter of practice and a matter of choice. A second important factor that the patients can be helped in is education. The rehabilitation therapist can actually educate the patient in understanding the importance of adhering to certain kind of rehabilitation schedules. For instance, he may be given live examples such as diabetes, which gives immediate results, can be used as an example for diabetes patients. They can be taught how to check how lifestyle changes or dietary restrictions actually immediately bring about results in the blood sugar measures, because such kind of immediate regulation can be very useful. That is one thing which can be done. Secondly, patients also need to be educated how on a long-term basis exercise and lifestyle changes can actually make a difference, and that these are not just discretionary choices that you either choose to do or not do. These are mandatory things that actually need to be done. Also, education can focus on improving the self-efficacy of the patient, making him feel that he can actually do it, motivating the patient, because once the patient feels in control of the situation, he actually ends up adhering to the treatment. Also important is to look at creative non-adherence, because many patients may actually adhere to the treatment, but this adherence may not be to the actual treatment. It may be to a treatment that they feel is correct. They may stop the regular medications midway and they may go into some other kind of non-conventional or complementary medications because they feel that gives a more proper effect. So in such cases, patients will need to be educated by the therapist why it is important to consult with the doctor before you actually go into unconventional or other kinds of complementary medications, because the interactive effects of all these medications can have a lot of detrimental effects. Conclusion. Now, in this chapter, we have understood a lot of things about why rehabilitation is important for chronic illness and what kind of rehabilitation is involved. It may be physical, it may be social, it may be vocational, but all of these are key areas that can help the patient come back to normal and continue with an active life. Now, whoever it may be, whether you are the patient or whether you are a caregiver, you are a family member, or you are a medical professional who is in some way involved in the medical team for a chronically ill patient, or you are a student who is going to deal with chronic illnesses, this is something that you should remember, that rehabilitation and professional rehabilitation is something that is very, very essential for chronic illness. It cannot be negated and it cannot be done away with for something else.